years ago, I was praying for this technology. When I was doing my transplant VAD fellowship over 20 years ago, I realized that we in this room are taking care of the sickest patients, sickest group of cardiac surgery patients, no question, hands down. They're all sick, even the transplants that go well. No matter how short your ischemic time is, you never know if that cocktail of drugs you came out with is going to keep them okay. You don't know if you're dealing with a situation where you need to change that cocktail, or you're dealing with tamponade post-op. It seemed to me that it was incredible that no one was really coming out with this technology. I said, couldn't you put it in an NG tube or whatever? So when ImaCor approached us, I of course embraced them. My cardiologist, being more practical, said, let's try it. And so they tried it, and they couldn't live without it. This has been invaluable. One of the issues that's been asked is, the cost. Administration gives us a hard time. We described how they were going to cut down on the cost of going back to the OR. That alone will pay for several probes. The morbidity post-op by waiting because you don't know. This is so simple. Our round-the-clock intensivists all know how to do it. Our cardiologists, I don't have to worry.
hTEE is the only technology that nowadays is used at the bedside in the critical care patients in order to continuously visualize directly the cardiac chambers. And because it's giving us important information about hemodynamics and how to manage this hemodynamics, the hTEE actually improves patient outcome, shortens the length of stay, and reduces the ICU cost. It's a very small probe, it's very easy to handle, and enables continuous and episodic assessment and optimization of cardiac performance. And in our ICU setting, not only the intensivists but also the cardiologists are using this at ease. It's very important to have available a probe on a portable machine at any time of the day and the night, not to depend on the echo tech or the echocardiologist to come to the echo machine at the bedside on their own schedule, and has the very big advantage compared to a standard TE probe for long-term monitoring up to 72 hours in the hemodynamic parameters in the ICU setting.
Indications for hTEE are evolving. That is, so if we're thinking patient tamponade or the hemodynamics are abnormal, it's very convenient to place it in very quickly in the ICU. Our mid-level providers are now proficient at doing them even without the residents. We've taught our surgical house staff how to do it to handle our patients much better in the intensive area.
Most of you, I'm sure, are familiar with this vicious cycle of managing the vasoplegia, the hypoperfusion, the resuscitation you need while trying to balance potential RV overload and dysfunction. The bleeding contributes to that, and the RV dysfunction obviously contributes to further hypoperfusion. The way I see this is the probe helps us kind of break this cycle in terms of if we have a good real-time assessment of the RV, then we can push all these other things that we need to get this patient through with less worry of the RV, because it's often guesswork in terms of how much you can do without hurting the RV. So this takes the guesswork out. So it's very easy to use with minimal experience. I had no formal training or didactic or introduction to this. Basically, I just saw a couple of people use it, and it got my hands wet in terms of just playing with it, and within 1 or 2 tries it was very intuitive, and we're able to do it on our own without having to call in a echocardiographer or a cardiac anesthesiologist. And from a practical sense, it makes a lot more sense in terms of getting things done faster and with the limited resources that you may have. It's starting to become part of our regular armamentarium of things that we can do to help maximize the treatment of our patients.
Like anything else, you guys remember the days where VADs, the initial startup cost was $250,000 to $500,000 to bring in a VAD. Like anything else, this is going to just take some convincing, but as more and more centers do it, I think you're going to realize that this is going to become the standard of care.